Welcome to Bhekisisa's third webinar for this year, and thanks very much for joining us tonight. I am Mia Malan, Bhekisisa's editor, and for those of you who are not that familiar with Bhekisisa, we are a media startup based in Johannesburg, and we specialize in health reporting and initiating discussions around health policy issues. Bhekisisa is presenting tonight's webinar in partnership with the Healthcare Workers Care Network and the United States government's President's Emergency Plan for AIDS Relief, PEPFAR. As you probably know by now, we will be looking at the mental health impact of epidemics such as COVID-19 and HIV on healthcare workers. Here is how our webinar will work tonight. It will be just over an hour long, and we'll spend roughly half of that time on presentations and opening remarks by our three speakers, and the other half we'll spend on getting our panelists to answer your questions. We're going to start off with a 15-minute PowerPoint presentation by Joanna from the Healthcare Workers Care Network, and then we'll have short introductory remarks by Tshepile Tlali from the Junior Doctors Association and by Francois Fenter from Bhekisisa at WITS, and then we'll move on to your questions. Many of you have sent in questions when you registered for the webinar, so I will ask the panelists some of those questions, but I will also incorporate the questions that you enter into the chat box here on Zoom or the chat section on YouTube if you are joining us via the YouTube link. Before we start, Bhekisisa will be live tweeting this webinar. So if you wanted to follow those tweets, you can follow us on Twitter. Our handle is @Bhekisisa_MG. And if you wanted to live tweet yourself, we are using the hashtag Bhekisisa webinar. Lastly, if anyone has their video function turned on, except for the speakers, could you please turn that off now? We'll now start with our first speaker, Joanna. Joanna is a specialist psychiatrist and has chaired the mental health review boards for Ekurhuleni in 2018 in the wake of the Life Esidimeni disaster. She helped to launch the Gauteng chapter of the Healthcare Workers Care Network that offers free mental health support to health workers. Joanna is going to explain to us what moral injury is and also talk a little bit about the kind of mental health challenges that health workers face during epidemics. She's mostly going to focus on COVID and moral injury. We will hear a little bit more about the HIV side of things from Francois Fenter in a bit. Joanna, over to you.
Please unmute her if she's still muted.
Joanna's just getting a presentation ready. You ready, Joanna?
Yes. Can you see my slides?
Yes, yes, very clear.
Right, thank you. So I'm going to introduce the concepts, and we're talking about moral injury and related concepts. And now my slides are not moving. But this has happened before and I just waited and then they started moving. So I'm just going to see if that works. Sorry about this. Sorry.
That's okay. Joanna, if they're not moving this way, then you can also do the screen where we can see your slides on the side as well, if that's easier.
Okay, let me go back out and reshare. Sorry about that. . Okay, so I'm just going to do it this way.
It's okay.
All right. Okay, so we're starting with these, with the concepts. And the language of moral distress and moral injury have gained ground in the healthcare context to articulate something more specific than the idea of burnout. And these concepts can enrich our thinking about the psychological effects of extreme working conditions and what the most helpful types of support are. And the terminologies emerged from nursing literature and has been adapted from military trauma research. And it includes the concepts of moral dilemmas, moral distress, and moral injury. And so you might be thinking, why are we talking about morality? So morality is to do with right and wrong, but it's also to do with who we are in relation to others and to society. And healthcare workers often think of ethics in relation to their professional role, and moral positions are a bit broader. And they bring all of these news headlines into play. And healthcare workers are not acting in isolation from the world around them. And the strong theme in the international research about what's into this pandemic, about what predisposes healthcare workers to the mental health effects of working in this pandemic, has been that they're much more vulnerable to the mental health complications when they've had colleagues directly affected by the virus, particularly if fatally so. And it's interesting, I think, to talk about this now in this kind of hiatus in which we find ourselves at the moment, where we're waiting to see what happens next with a second wave and hoping that frontline workers are catching their breath. But if we look at some definitions to start with. So moral dilemmas are expected, difficult parts of clinical practice. There's often no comfortable answer to the problem posed, and training needs to offer best practice approaches that include ethics consultations, team discussions, and supervision. And opportunities to grapple with dilemmas like this with appropriate support and guidance make for clinicians capable of crafting sophisticated and compassionate solutions to complex problems. So if we all imagine a recent thorny problem that caused us to seek advice, this is routine professional practice, makes for interesting, rich, and challenging work, and healthcare workers wouldn't want such complexity to be removed from their experience. And then we come to the idea of moral distress. This is what occurs when an individual knows the right thing to do, but institutional or other constraints make it difficult for them to do what is right. And there's an idea that each episode of moral distress is either resolved with sufficient processing or leaves something called moral residue. And moral residue is constituted by the unresolved emotional and psychological conflicts that make subsequent incidents less tolerable. So moral distress places us in the zone of a normal response to an abnormal situation, where serious adverse mental health outcomes are not inevitable, and therefore it's really worth optimizing preventative and supportive measures. And then we come to the idea of moral injury. So moral injury is a term that was initially brought into mental health literature by the psychiatrist Jonathan Shea in the 1990s, and has come to be defined by Litz et al. As resulting from perpetrating, failing to prevent, or bearing witness to acts that transgress deeply held moral beliefs and expectations. And in healthcare, these beliefs and expectations include the oaths that individual healthcare workers took to provide the best care possible for their patients and to make a patient's needs the first priority. So while recent use of the term in medicine has been related to the pressures on clinicians in the context of the modern healthcare system, the current pandemic seems to bring together some of the older trauma-based roots of the term, used to develop understanding of symptoms in Vietnam veterans, and the more practitioner-related burnout-based meanings. And the current context offers a confluence of taxing occupational demands alongside dealing with loss and grief. And then if we think about the South African context, South African healthcare workers are no strangers to tight rationing of resources, nor to encountering brutal trauma in the course of their daily work. So an interesting question is, will these cumulative experiences make our healthcare workers more or less vulnerable to the unique stresses of the COVID-19 pandemic? Will the layers of moral distress and injury from working in the apartheid healthcare system, working through the AIDS denialist era and the pre-ARV peak of the AIDS epidemic, and then trying to deliver services through the pillaging and crumbling of the last decade, confer strength or vulnerability in the face of this new crisis? Private healthcare has its own challenges, including isolation and the heavy burdens of sole responsibility. And of course, the healthcare workers in that system are shaped by their training in the state sector. And it may be that the determination and ingenuity required to continue to deliver care in each decade will mean that many healthcare workers have laid down crucial neurological pathways for this pandemic. This was written by a friend and colleague, a medical school classmate of mine, now working in the Eastern Cape. I asked her permission to use it, and I put it here not only to remind us of the immeasurable loss of Prof. Pepeta, but because her words tell us all we need to know about how such a loss affects his colleagues. Much has been written about who he was as a doctor, a leader, a researcher, and a father. These words give us a sense of the context of this loss for those left at the front lines, and the despair and anger that come through speak to the heart of the moral distress. And she wrote, "I can't deal tonight. This is just too much. I counted 10 healthcare workers dead in my province just this week. There isn't time to attend Zoom and drive-by funerals. How do we rebuild this service? Prof. Pepeta is irreplaceable. You can't magic pediatric cardiologists of this ilk overnight. It's an unquantifiable loss to our community. Dean of the new medical school. He wore so many hats. The people who have stolen PPE money and not made adequate protection available to us timelessly are really the immoral scum of the earth. The medical service cannot withstand this kind of loss." The last statement I saw from Minister Mkhize about COVID-related healthcare worker deaths was in mid-August and gave a number of 240, 37 from the private sector and 203 from the public sector. And I noticed an interesting reaction when I was putting this presentation together tonight in myself, that I almost thought of taking this slide out. I thought, it's a different phase now, and do we want to be talking about all of this? And I think that is a particularly dangerous moment at this time for the healthcare workers who have lived through the real coalface of this pandemic, that there's a sense of other people wanting to move on, and that they are really still sitting with this. This is a quote from Rolling Stone magazine a couple of months ago that says, "The measure of wealth in a civilized nation is not the currency accumulated by the lucky few, but rather the strength and resonance of social relations and the bonds of reciprocity that connect all people in common purpose." And I'm emphasizing the social contract because the essence of the idea of moral injury is that this is not something that goes wrong with an individual. This is something that goes wrong between an individual and their society. So while the moral injury scenarios in the South African COVID-19 epidemic have not looked quite as we might have predicted, what we see is that stretched and increasingly managed healthcare systems globally were already a breeding ground for moral distress and injury. And the COVID-19 pandemic then magnifies the pressures in a number of ways. So end-of-life decisions and care have been made harder in the absence of family members. There have been various levels of risk undertaken by all frontline workers. There have been many day-to-day clinical dilemmas. So for example, oncology services that were suspended, and practitioners knew that their patients' prognoses were worsening day by day and were worried about them. The TB and HIV service underutilization, which was weighing on the minds of all healthcare workers, neglect of chronic mental health care services, and I think all chronic healthcare services. Then there were PPE shortages, which were worsening the risks of healthcare workers and the choices faced between personal and professional obligations, the losses of colleagues, patients, family members, and friends, and then the growing caution fatigue that I think was being experienced by everybody. I have quite a bit in here about rationing. And in the preparation phase, it seemed logical that rationing was going to be one of the major sites for moral distress. Rationing of healthcare resources is something that we could place in the category of a moral dilemma. And if well managed, it does not have to result in undue residue and injury, although there may well be some distress. And South African healthcare workers are very familiar with rationing and know that it can contribute to sound clinical decision-making. In fact, many of our healthcare workers will tell you that being forced to think very carefully about resource allocation makes for much better medicine, for which we are well known. But if protocols are unclear, out of date, or non-existent, support is not in place, and systems are overwhelmed, the pressures on individuals to make and convey rationing decisions will lead to moral injury. So in March 2020, professional societies and ethicists were swift in providing guidance on such matters as the rationing of ventilators and ICU care, and many South African hospitals quickly endorsed the Critical Care Society of South Africa's guidelines of 2019. And I remember following the publication of each guideline eagerly looking for answers. But of course, what emerged over the coming months was that most of the painful and taxing decisions for healthcare workers presented themselves lower down on the decision-making tree before one might have the benefit of a manual. Who to admit to hospital and when, how to explain to families how you are allocating an oxygen outlet, whether to continue certain essential but not quite urgent services, whether to go to work with mild symptoms and risk infecting others or stay at home and know that your team was taking strain. The list is long. And many healthcare workers have also struggled with distress and ambivalence about current allocation of resources after years of witnessing a healthcare system stripped bare, with the resulting thousands and thousands of deaths and reduced quality of life each year from preventable causes. So we've covered some of the context. So if we go back to the nature of moral injury, the definition in a mental health context is the profound psychological distress which results from actions or lack of them, which violate one's moral or ethical code. And these can include acts of perpetration, acts of omission, and experiences of betrayal from leaders or trusted others. How it relates to mental illness is important because moral injury is not a mental illness, but experiences of potentially morally injurious events can lead to negative thoughts about oneself or others, deep feelings of shame, guilt, or disgust, and those in turn can contribute to the development of mental health problems, including depression, PTSD, and anxiety. A slightly broader conception of moral injury is that when it does occur, the range of outcomes can include feelings of guilt, shame, anger, sadness, anxiety, and disgust, intrapersonal outcomes including lowered self-esteem, high self-criticism, beliefs about being bad, damaged, unworthy, or weak, and self-handicapping behaviors, interpersonal outcomes including loss of faith in people, avoidance of intimacy, and lack of trust in authority figures, and existential and spiritual outcomes, including loss of faith in previous religious beliefs and no longer believing in a just world. So if you know anything about PTSD, you can see the links here with PTSD, but there's a specific emphasis on how this damages one's relationships with oneself, with others, and with one's place in the world. And then lastly, just to look at the factors that increase the risk of moral injury. And those factors are loss of life to someone who's considered vulnerable, if leaders are perceived not to take responsibility for the events and are unsupportive of staff, if staff feel unaware or unprepared for the emotional or psychological consequences of decisions, and if the events occur concurrently with other traumatic events, for example, the death of a loved one, and if there's a lack of social support following the potentially morally injurious events. So that's some of the background, and I'm going to leave it there for now, and then we'll be ready to take questions later. Thank you.
Thank you very much, Joanna, for that really insightful presentation. And thank you for making it so relevant to the South African context and our COVID epidemic. And I think our next speaker is really going to be someone who lived in that situation of all the theory that you talked about now. We are going to move on to Tshepile Tlali, who is a public sector doctor in the Eastern Cape, and he's been treating COVID patients for the past 6 months. It's almost the only patients that he has seen for the past 6 months. And Tshepile is doing his community service here at a community health center in Mdantsane, and he has had COVID himself. He's also the acting chairperson of the Junior Doctors Association. Tshepile, as a public health doctor in a really under-resourced province, please tell us what your experience of moral injury and mental health challenges have been when working with COVID patients.
Thank you very much for your question, Mia, and good evening to the audience. Wow, I can't believe it's been 6 months already. But as you mentioned in your introduction, I work at Nontyatjambo Community Health Center in Mdantsane, which is the second largest township in South Africa. I've been working in the forefront of seeing COVID patients for, as you've said, the last 6 months. And how I came into working in the forefront is it was influenced by the amount of fear which was surrounding the condition. I think all healthcare workers were afraid of contracting the virus and the impact that would have on them. And that influenced me to start reading a lot about the virus. I wanted to know everything about it, how it works, how long you're infective, what kind of illnesses you can get from it. And I realized that the more I read about it, the less scared I became. And naturally, then I kind of gravitated towards the COVID-19 pandemic at work, and I was also involved in implementing safety protocol at the institution. My experience with moral injury, firstly, it was when the Department of Health and the NHLS instructed us to to be more selective in who we test. That created quite a challenge because as the numbers started to rise up, we had a lot of people who came to the clinic that we couldn't test based on their risk factors. And that for me left me very worried about the fact that they would go back to their communities, even though we've told them to treat themselves as someone who's COVID positive and to isolate. The fact that the diagnosis was not certain might not force them or encourage them to stay at home and protect others. And furthermore, it would mean that they would not be on the list of people who would be traced. And that would mean that their contacts might get the virus, and their contacts might get the virus, etc. And as you can see, that would start a whole new outbreak in a certain area. And I felt a little bit responsible if that would happen. Furthermore, as the number of cases started to grow, we started experiencing quite a big backlog. At the beginning of the pandemic, we were told that the turnaround time for test results would be 2 days. But as the numbers started to go up and up and up, at some stage in the Eastern Cape, the NHLS had a backlog of about 20,000 cases. And that meant that we went from 2 days turnaround time up to 4 weeks turnaround time. And for some people, it would mean that by the time the results came back, it was irrelevant because they would have recovered from the virus. That also impacted us at work because if somebody who tested for COVID had to go quarantine for 14 days, and it so happens that after 14 days, when the results do come out eventually, they are negative, it means that we lost pair of hands that we needed at quite a crucial stage. Then the next form of moral injury experience was due to the ambulance shortage. In the Eastern Cape, we already have a massive ambulance shortage. Now, compounded by the COVID-19 and their quarantine and their staff members also quarantined.
Cherry tomatoes for salad. Salad.
Someone has their microphone on and we can hear you. Can you please turn it off? Can you please, Mamatu? Yeah, thank you very much. You can continue, Tshepile.
So as I was saying, that we have quite a massive ambulance shortage in the province, and now compounded by the fact that they were also being affected by the virus and they also quarantining, it meant that they were also kind of working at half the complement. That further worsened our ambulance problem. And now when we did have ambulances, the issue was that they were also affected by the fears, If you had a patient who was a PUI and a patient who wasn't a PUI, they would kind of gravitate towards the patient who was a PUI, and that kind of left our patients stuck at the institution when they need to be referred to a higher institution, which is Cecilia Makiwane Hospital for us. Furthermore, due to our safety protocols, it meant that the PUIs that we were seeing, we had a separate place on the outside of the institution. It meant that they would wait there with oxygen cylinders that you weren't sure when they would finish. And I felt that for very, very sick people who were sitting outside in the middle of winter, that stripped them of their dignity. As the numbers started continue to increase, so did the patient load, and so did the burnout in me and my colleagues. At some stage, towards the peak, we started seeing about 60 to 80 people every day. Those are people who are just who are presenting with COVID symptoms. That doesn't include the number of people who are coming to clinic anyway. And seeing these patients with about half the staff complement at Nonjetiambo, who the other half was either in quarantine or in isolation with the virus, it became very, very strenuous. You know, I started getting burnt out. I became irritable. I just wasn't myself. And I started developing a sense of apathy in my work and in my life. Certain things, though, that keep you going as a doctor is maintaining a certain level of respect and care for your patients. And I found myself, you know, not caring. There came a time when my colleagues, my friends were asking me to just take a break. You know, they could see that I was run down and I didn't want to take a break because that was the moment where I was needed the most. But fortunately or unfortunately, I contracted the virus. And although it wasn't an easy time, well, living with the virus, I think it was a blessing in disguise because that gave me that time to rest and recuperate. And I came back and I continued fighting the virus. And luckily now we are taking a break, taking a breather. Thank you.
Tshepile, thank you very much for that. It was really insightful what you've said, and it's made Joanna's presentation come alive. So many of the things she mentioned, you have experienced. And thank you for giving us a look into the life and the working environment of a COVID doctor. Now, let's move on to our last speaker. COVID is, of course, not the only epidemic that South Africa has seen. HIV has been with us for more than 3 decades. And Francois Fenter, who is an HIV scientist and also the head of Zinsa at WITS, was a public sector doctor during a time when patients in government clinics didn't have access to any treatment. Francois, what were your experiences of moral injury during this time? And do those experiences differ from what COVID doctors like Tshepile experience today? And are there, for instance, any lessons that COVID can learn from HIV?
So I'd never heard the term moral harm or moral injury before, but it was a very quick resonance, I think. You know, in the early 90s, late 90s, early 2000s, I think we just saw this steady wave of people entering the hospital. I was a hospital-based doctor. I wasn't involved in primary care, but we just had this flood of people, and it was this silent epidemic. I think what people thought with COVID is people would be dying in the malls and dying on the streets. And similarly with HIV, what was actually happening is people were dying in the hospitals or they were dying at home. And it was a source of shame and of quiet and stigma. And some of that, I think, we are seeing in COVID. You know, certainly in other countries, there's been a huge number of deaths at home. And people are, even here, people are being quite loath to say if they, you know, if a family member has died of COVID. But what we had certainly in about 2003 was just hundreds of people dying on the floors of the hospitals. The hospital I was working for, you know, here in central Johannesburg, most patients actually died on the floor at the peak of the epidemic before we had the ARVs. And it was terrible because I think the way many staff started to deal with it is started to treat them as subhuman. Academics, clinical staff, not everybody, I think many people tried their best, but it was the only way I think mentally to actually deal with a government that was just denying there was any problems whatsoever. I remember Mbeki coming on the television and talking about how he didn't hear that the hospitals were full. And Mbeki lives literally 500 meters from the hospital where I was working. And just needed to walk through the door. We could take him to the medical unit and we could show that people did not have enough beds. Now, I don't think that ever hit the COVID. We never saw those numbers here in South Africa around COVID, but it was, you know, it was the kind of sense of a disaster that nobody was willing to take seriously. The society didn't want to hear because I just think it was overwhelming. Medical staff didn't know what to do because it was so overwhelming. And government was in denial, which, you know, and certainly in COVID initial stages, we didn't have that. I think the thing that hurt me so much is there were a limited amounts of ARVs available. And as an ARV doctor, I was treating senior politicians who were sitting in the cabinet at that stage, supporting Mbeki and Amantu and all these denialist people. And I think the moral outrage I felt at the same time as watching them saying you can't have ARVs because they're toxic, because while they were treating them, I was treating them, their family members, their domestic workers, was just, and I'd say to them, it's like, why are you doing this? I'd be like, politics, blah, blah. I'm like, people are dying around here. So I think there was a real sense of moral outrage at the time, and that normalized. Paradoxically, Zuma came to power and the ARV program has made huge strides and things are normalized. There's lots to be worried about, but that kind of sense of moral injury, I think, sort of dissipated with time. I think your previous speakers talked about two things that really resonated with me in terms of moral harm at the moment. The first was around PPE. HIV, there was a fear of contracting it as a doctor, as a nurse, as a pharmacist. That is so much worse with COVID, especially when we didn't know quite how terrible it was. Is that as an individual, of taking it home to your family members, of taking it back to your patients, of you getting sick with it, was all there. For healthcare workers, in many ways, COVID, I think, has been far more of an assault, immediate assault on us. By the time HIV hit us, we knew how to protect ourselves with gloves, with post-exposure prophylaxis. So that's the issue around PPE and the corruption that came around. I think for all of us, I think for the communities as a whole, but for healthcare workers, felt like such a profound betrayal. This is the stuff we need to make our jobs safe, and you went and looted the state in the process of getting that. And I think for all of us, as I said, I don't think it's just medical staff, but I think we felt it particularly profoundly. The second thing was the instance you heard about the testing strategies. And for me, this is where my role, within the policy debate, being on the Ministerial Advisory Committee and all the rest, the frustration of trying to get scientific processes in place and government making insensible turns, making policies that didn't make sense around, particularly around testing, which is a complicated area, but where they didn't prioritize correctly, where they were, they were playing politics rather than actually playing to the hospitals, where the impact was really being felt, certainly in central Johannesburg at the time, making insensible decisions and then going to the media and trying to explain it away as a human rights issue when it made absolutely no sense. And I think the final thing that I felt morally outraged probably by, I was watching President Ramaphosa coming on, he's played this very leadership role, but coming on television and one of his announcements saying, we really worry that young people are going to parties, and certainly for me as an infectious diseases doctor, this is one of the most profound things, is physical distancing is desperately needed. But the government, the couple of days before that, said it's fine to go to church, and that hypocrisy, that lack of transparency that unfortunately has characterized the South African response from government has, I think, for me, been profoundly I certainly felt like it's a moral injury, that it's raised my anxiety, it's decreased my trust in the powers that be in a situation where we desperately need a coherent health response from our government. So I think in many ways, HIV's ended up in, COVID has ended up where HIV was, which is this terrible space where I don't trust government responses. I want them to be as strong as possible. I want them to do the right thing. I'm investing in this country and in this healthcare system. But the missteps that are taking place at the moment, missteps that just aren't, I was watching the list of countries being listed for international travel this evening, make absolutely no sense. And I think for me, having coherent, transparent science behind things is absolutely, part of my DNA in terms of trusting the public health response.
Thank you very much, Francois, and thank you for giving us a perspective from both the HIV and COVID-19 side, and also the differences and similarities between the moral injury that's experienced between the two epidemics. We're now going to move on to questions. If you have a question that you'd like to be answered, please enter it in the chat box of Zoom. I haven't seen any questions there yet, but please, if you have one, I've seen comments. Many people thanking Dr. Tlali for sharing his experiences. If you have a question, please enter it there. I'm going to ask questions in the meantime that you have asked when you registered. There's a question for Joanna. Joanna, someone wants to know, is there a difference between moral injury and post-traumatic stress disorder?
Yes, so moral injury can predispose to mental illnesses of various types, but it's not the same as a mental illness, and it doesn't necessarily lead to mental illness. So post-traumatic stress disorder is a specifically delineated clinical syndrome, and moral injury is one of the things that can predispose to something like that. So they share characteristics, as I showed in that one slide, where there are quite a few shared characteristics, but they're not the same thing.
Can you maybe give an example to explain what the difference is, maybe in a health context?
So post-traumatic stress disorder has quite specific symptoms, including, for example, hypervigilance and re-experiencing of a traumatic event, and specific symptoms like nightmares and numbing and dissociation, and you can have mood changes, depression, raised anxiety, etc. And moral injury is, as we've discussed the definition, and it can predispose to depression, anxiety, post-traumatic stress disorder, but it's not one and the same thing.
Thank you very much for that. Sorry, Joanna, did I interrupt you?
No, I was just asking if that clarified it.
Yes, absolutely. Thank you very much for that. We have had quite a few questions from registration around what can be done to support health workers with moral injury within a health environment. And I wonder if we can start with Tshepile to ask, have you received any help? What do you do at your clinic in a work environment to cope with the mental health challenges that COVID has posed to you?
But I'll try to simplify it. I think the most important thing is realizing that you are working, you're going through this pandemic with everybody that you work with. I think we were quite fortunate where we work that we managed to build a sort of unity that, we were understanding that everybody is struggling, everybody's pulling their last straw in order to give their best in the situation. So having people around you and keeping those who can make you feel better, very close to you, that was very helpful. Furthermore, and we thank Joanna Taylor for introducing the Healthcare Workers Care Network. That is a free facility for all healthcare workers, regardless of whether they're clinical or administrative, to access for free counseling sessions in isolation or in group settings. Thank you.
Thank you, Tshepile. Joanna, it would be great if you can tell us what the Healthcare Workers, your organization does. There's also a question that from Ames Dye about that. Joanna, what are your thoughts on moral resilience? And as we go forward, could you advise on how healthcare workers build up this resilience? And I think that would be part of your answer of what you do with your organization.
So our network it grew out of a Gauteng chapter that was founded in March by a group of volunteer mental health care workers who started in private practice, but volunteers from state as well, who saw the pandemic coming and wondered what we could do to support healthcare workers in it, and started looking at the international research. It was started by my colleague, Dr. Antoinette Mirich, and she got a few people involved initially. And then it's grown into a national initiative. And based on the research, what we decided was that we needed to have a preventative arm and a treatment arm, because research shows that a lot can be done in terms of supportive work to prevent, as I've been discussing, to prevent the conditions that may grow out of moral injury, moral distress, etc. It doesn't necessarily need to progress to those kinds of injuries and conditions. A lot can be done to provide support, and a lot of that is done at optimizing team functioning in healthcare teams. And so we functioned much of our efforts there, and at this point we've actually done training on to 3,200 people in different healthcare teams around the country to optimize how teams are functioning. And then the other arm is a treatment arm where we offer free therapy services through a volunteer helpline. And so that's the kind of broad description of what the network does. In terms of Professor Dye's question, so we have started to think quite a lot about post-traumatic growth, moral resilience, etc. And that is certainly one of the possible outcomes of a time like this, when people reflect and they feel like they have done their best in a really difficult situation, and they have done something meaningful, and the rupture between themselves and the society around them has not been too great. It seems that they can end up with a deeper sense of meaning and purpose in their work and in the bonds between them and their patients, themselves and their communities. And there are actually some studies coming out about that, mostly from nursing care in China and some early work in the UK, showing that some of that meaning and purpose is deepening in the work there. But I think it very much depends on not having that total loss of faith that we're hearing those threads of coming through in what Tshepile and Francois are saying. And also in feeling supported by your supervisors, by your hospital managers, by the provincial structures, etc. Those are some of the things that are protective.
Thank you, Joanna. Francois, during the HIV years, did you receive any of the support that Joanna has mentioned? I remember as a young journalist during those years, how people like yourself and other doctors became a part of a very strong activist community. So did you get support from your health environment, or did it lie more within the activist community? How did it work?
I think something that came through, and I sense, talking to people, just listening to my health colleagues, I think one of the lessons we can take from this is how proud I am of all the frontline clinicians. I'm not talking about me. I sat on my backside and did policy and tried to school myself and redirect our research efforts. But the generosity and the sort of cohesion, and I think this is one of the positives we're going to be taking out of this, is how important the healthcare system is, and seeing the society, showing the society that, and also showing how hard people work. I came from probably a different era. I did get a lot of support from my co-workers, from the activist community, and I think there was a real sense of fighting. It was like being back in apartheid. There was good, which was the HIV community, and there was evil, which was government. And I think that also made it in some ways easier. It actually became harder to be an activist during the Zuma and the Ramaphosa years in HIV, because they were doing the right things. So the kind of good and evil fell away, and a lot of the activism was slightly diluted because of that. So your short question about the mental health, I have a view. I think mental health is one of the most unaddressed things, certainly in the HIV field. It's probably one of the strongest predictors of adherence to your medication, far more than most of the research I do. And there's pitifully little paid attention, lots and lots of lip service, almost no resources. So again, I'm hoping out of this, I do think people, everyday experience of lockdown means everyone's much more in touch with mental health issues as a whole, because I think we've all been stress tested. So this is an opportunity also to start meaningfully starting to address those issues going forward.
And how do you think they can be addressed? Like, as an HIV scientist, what do you think patients need to then better adhere? What kind of mental health support?
So I think the medical fraternity needs to do some introspection here. We're really good at doing new tablets. All my research is about better and smaller tablets that are cheaper. The hard stuff, which is retinkering the healthcare system, starting to pay attention to mental health needs, to do the soft stuff, the touchy-feely stuff that lots of us are quite dismissive of, but which is probably far more important than 99% of my research. Starting to think about what that looks practically. There's a whole lot of innovative stuff for giving support to people through apps. One of the things I was thinking about, in terms of isolation, sort of lockdown stuff, is how important access to the internet is just to stop social isolation. These old people who are sitting behind cold doors, terrified that COVID's going to come and get them, like if they had Skype, if they had free access to, to communications and things like that, maybe that's something we can do that's practical in the short term, is making sure that every South African has access to internet access. And then for the medical fraternities, start thinking about what practically can we do instead of just coming up with more platitudes but no resources, and making sure that we put the pressure as activists on government to start properly putting forward those interventions.
Thank you. Tshepile, did you want to weigh in on that? I can see you nodding.
I completely agree with Francois. I like the out of the box thinking that he speaks of. I think the kind of pressures that we have to go through as healthcare workers in this country kind of doesn't allow you to think outside the box. And I really appreciate and I agree 100% that we need to start focusing on things the things that are not apparent to us but will make a big difference in the future.
Thank you, Tshepile. There's a question another really interesting question that I think all three of you would have something to say about. And it says, to what extent are mental health issues of health workers buried because they more than anyone know that it could have awful repercussions for their professional career path and their reputation? So given this, is there any indication of just how many affected healthcare workers there are with mental health issues and moral injury? And we just don't know about it because mental health is so stigmatized. Maybe we can start off with Joanna and then we go to Francois.
I mean, there's no doubt that that's a big barrier to care and treatment for all medical practitioners, for all healthcare workers. And that brings us to one of the most protective things, the most protective types of support available, which is peer support. And, one of the things that both Francois and Tshepile have touched on is how protective it is to have your colleagues and your activist colleagues to talk to rally with, to pit yourselves against government with. And what the research also shows is that is what people want. People working in extreme conditions want to talk to the people they know share their experience. They don't generally want to talk to people who they don't necessarily feel understand exactly what they're going through. So the best thing you can do is talk to your peers. And one of the most helpful things we can do is facilitate that peer support and not necessarily prematurely medicalize things that don't need medical solutions necessarily. So that's one thing I think is important to remember. But where clinical help is required, and it is required much more often than it is accessed, we need to make that much more available and much more acceptable to take up. And that is about role modeling, and it's about proper messaging from the very top and within teams. And that is definitely not happening at the moment. Something we can do much better.
Thanks, Joanna. Francois?
I think something profound that happened in the last 3 years for many senior academics in the medical fraternity was the suicide of Professor Mariosi. I'm at Wits, he was at UCT, but it was the first time I've seen one of the most open discussions amongst my peers. He was so respected and so loved by everyone, including by the other universities, just one of the nicest human beings. And it was so inexplicable that it almost gave this window of opportunity to start talking about these things. And for the first time, I think I saw open corridor discussions about depression and about the stress and the overwork and the toll on medical fraternities. What Joanna was talking about peer support, I've always maintained that the tea room for doctors is probably the best therapy moment. We sit and we bitch and moan about our patients and our conditions and all the rest. And there's a sense of solidarity. And I've often thought that with nurses who are much more disempowered in that situation, they don't often have, they're not on the top of the decision pile often, unless you're a matron. And they often don't have those venues to be able to talk about the scientific stuff and the kind of the medical stuff that the doctors often have power over in terms of prescribing and understanding. And I think that it's interesting, those hierarchies, we're going to need different probably different interventions for different tiers of staff in terms of what they do. We've done a whole lot of work on mental health of nurses around central Johannesburg who do shift work, and discovering the intense stress of their home life. In fact, there's this terrible quote in one of the research studies we did on how nurses use money, and they talked about the stress of their home life, and they said, I go to work to get away the stress of my home life. And that's why I think that these things are going to need quite sophisticated and adult discussions as to what we could do to make sure that healthcare workers are better supported in every aspect, not just in their occupational, it's not about PPE. There's a whole range of other stuff we're going to need to consider.
Thank you. And I think your comment speaks really well to a comment here in the chat box from Robin Lee Nodia, who says that we must remember that health is not just medical and clinical, but holistic, and that we need holistic support for health workers. Tshepile, did you want to weigh in on this issue? You unmute.
Yes, yeah. That question is very triggering. I think the issue comes from the culture of the medical fraternity. From my experience, and it's been quite a short journey, the medical field is quite hierarchical and authoritarian. And from a young age, you get taught to be resilient, even beyond the measures of your mental resilience. Any sign of lack of resilience is portrayed as weakness. And going throughout university, you know that even if you're not coping, you better put on your shirt, better put on your clothes, get ready, go to work, push. You will deal with it whenever you catch a breather. And that kind of mentality gets ingrained in you for the rest of your life, professional life. Getting into varsity and now wearing my Judasa cap, we deal a lot with people who are mentally stressed, who they suffer a lot. They suffer from mental health illnesses. They suffer from moral injury. They suffer from a lot of the stresses that a lot of doctors suffer from, and other health workers for that matter, in the public sector at least. And you approach them and you ask them and you give them advice on how to deal with these issues, and usually you're met with a bit of resistance because they don't want to be portrayed as weak. And that kind of mental oppression, for lack of a better word, leads to poor health-seeking practices. And I saw Cassie asking quite a question about how we can encourage more healthcare workers to reach out for healthcare, for mental health care services. And the way to answer that question, really need to get to the bottom of the determinants for this kind of behavior. And only when we understand that, that the medical field needs to be rewounded into a more open field for people to experience to experience whatever they need to experience to deal with everything that we deal with. Only then we can start having more people access mental health services.
Thanks very much, Tshepile. And we have another question from Ames Dyer. That is a really nice question to end our webinar with, because it looks a little bit ahead in the COVID situation. It's about COVID vaccines. And Ames is asking, there's much discussion about the COVID vaccine where the demand outstrips the supply. And she would appreciate all three of you, your thoughts on moral distress at the time of rollout and how prioritization would cause this. Joanna, we can maybe start off with you, and then we can go to Francois and then to Tshepile.
I was thinking maybe Francois should start with this one.
Okay, let's start with Francois.
So I think the vaccine nationalism we're seeing, we're looking for international solidarity, and I think medical staff certainly have shared their experiences across countries, left, right, and centre in a way that is unprecedented. clinical and research careers are being shelved so that people can just work together to do this. And watching Trump and other rich countries buying up all the vaccines so that we're going to be at the back of the queue is, I think, is an injury. I think internally there's a discussion we need to have, because in many ways there is a chance that we've got like 55 odd million South Africans, that we're only going to get 1 million doses of the vaccine, and we need to have a preliminary discussion about who we prioritize for that. We cannot continue to have a situation where the rich, or those who can afford to buy the vaccine, or who can buck the system, are going to be able to do that. And I think that's a discussion that we can start having early on. It's the same discussion we need to have about how do we prioritize resources to protect the vulnerable? How do we make sure that your granny and grandpa, who are incredibly vulnerable to the consequences, can be supported in the background before they can get the vaccine? So yeah, I think internationally it's a sad state watching rich countries look after themselves. So Ames is completely right. It's something we all need to be outraged at. But there is something that's coming at us where rationing around the vaccine is something that allows us to have those difficult conversations up front.
Thank you. Shall we move on to you, Joanna, and then Tshepile?
I think while we have to protect the parts of ourselves that need help, for example, by allowing ourselves to be vulnerable and encouraging each other to seek help, when it comes to these issues where our moral distress is triggered, we have to be fierce, and we have to speak out, and we have to be advocates, and we have to be activists, and we can't let that drop. We have to, and when we get fatigued, we have to pass the baton to each other, because we just have to keep doing that. I was listening to Tshepile talk about how resilience, even these very useful concepts like resilience, the institutions that we work in turn them against us. So we have to be continually vigilant and on the lookout and advocating for each other. And we just have to keep doing that while we also create gentle treatment spaces for each other.
Tshepile, thank you, Joanna. Tshepile, I'd like to end with you to comment on that, but to also comment on a question that has come in about what about the family members of frontline workers? What kind of support do they need? And you are, working in a clinic and have a family, so you could perhaps comment on that as well.
In terms of the rationing of the vaccines, this is nothing new. We always, since I've started working, all resources need to be rationed. And I think, as Francois mentioned, there needs to be an equitable way of doing it. It must be free and must be fair to everyone who qualifies for it. So, I think that the most obvious thing you would say right now is that, okay, elderly people with risk factors would probably be the ones who are in line to get it first, whereas younger people with no comorbidities, they are unlikely to get it. But that whole process and trusting that the government can get it right will need to be done. In terms of the mental health support for family members of healthcare workers, I think it is quite important for healthcare workers, especially those who understand the virology and the pathophysiology of this virus, to be the reassuring factor for the family members. I think it is quite important, when somebody comes to you and they ask you a question as a doctor, "Hi, doc, do you think I'm going to die from coronavirus?" And you say, I don't know, I'm also scared I'm going to die. They also start panicking. But if you use kind of the science that we've learned, and science is more of a probability than a certainty. You say, from what I've read, you are unlikely to get very sick and die from it. So just protect yourself and protect everyone else. And I think doctors need to be that kind of reassuring thing for their family members. But if there is access to mental health services, it's very important, because, as I've said, everybody has been suffering from this, not just me. Everyone, the people I live with have suffered. My parents have suffered. everyone has suffered and has been affected by the virus, whether they were infected or not.
Thanks to Tshepile. Thanks for ending it on such an honest and really frank note of what the needs of health workers are. I am very excited and encouraged by the lively chats that's going on here in our chat box. And I see a lot of comments that thank Francois and Tshepile for sharing their work experiences and being so honest about it, and for Joanna for explaining what moral injury is. And I think I want to read one or two of the comments that really summarizes what we discussed today. Karen Lee Masters has written, mental health and psychological issues need to be normalized as being an integral part of the human experience and beingness. And I think that is something that has really come out of this discussion. And she's also said there's sadly still a stigma attached to mental health issues as being that of madness or crazy. And this needs to be challenged in every way on every platform possible, which is also an issue that all three of you have really raised. And Robin Lee Naudia has said reframing help seeking as a wise choice, not a weak choice, as you have pointed out, Tshepile. And why can't we be more vulnerable and admit that we're struggling? How can that be an illness? I'm very grateful for these comments because it really adds to the discussion, and I would like to thank participants for that, and for our panelists for really being frank and honest and explaining issues in such a really understandable and powerful way. And I'd also like to thank our partners again, the Healthcare Workers Care Network and the US government's PEPFAR program for their contributions, and for PEPFAR for their sponsorship of this webinar. The recording of this webinar is available on Bhekisisa.org. We will be creating a resource page that will be available on Friday, but we'll send out the recording of the webinar already tomorrow in an email to all of you. But on Friday, there will be a resource page with a link to the recording of the webinar, as well as a summary of the key points raised, and also a link to Joanna's presentation. I know many of you have asked for the presentation in the chat box. We'll be uploading the presentation there. And as I've mentioned, tomorrow morning, we'll send out an email to all of you who have attended with links to the recording of the webinar, and also a link to our website so that you know where to find the resource page should you need it. I would like to thank all of you for joining us, and please stay safe and social distance and wear your masks. And until our next Bhekisisa webinar, we'd love to see you again. Thank you.